Thank you for this opportunity to present our work looking at transrectal boiling histotripsy ablation of the prostate. Here you can see our disclosures and our research funding. Recent advancements in imaging technologies as well as ablative technologies have led to renewed interest in prostate cancer focal therapy. Initial clinical results with contemporary thermal FUS systems appear promising, with 5-year failure-free survival rates similar to what would be expected with contemporary treatments such as surgery and radiation, while maintaining improved quality of life with improved urinary control and sexual function. However, existing thermal systems do have limitations, including thermal diffusion related to relatively slow heating and minimal real-time feedback on ultrasound, and these factors have likely contributed to 15 to 20% of patients having positive in-field biopsies following treatment. Boiling histotripsy is a pulsed focused ultrasound technology that uses millisecond duration pulses with shock fronts to induce boiling bubbles at the focus. Interactions of the shocks in the ensuing vapor cavity produces precise, non-thermal mechanical tissue ablation. We hypothesize that the combination of BH's non-thermal mechanism and the presence of bubbles and subsequent loss of tissue scattering and resulting ability to monitor in real time could improve prostate cancer ablation outcomes. Accordingly, we have developed a prototype preclinical transrectal BH system consisting of a 2 MHz FUS transducer with similar size to existing thermal transrectal HIFU systems with inline beam mode imaging integrated to a clinical imaging platform and a Velmex robotic positioning system. Here we evaluate the feasibility of transrectal BH of the prostate, first in ex vivo fresh canine prostates and fresh human prostate tissue obtained from the OR. Tissue is embedded in 1.5% agarose and then treated. We then transitioned to the in vivo model where transrectal prostate ablation was performed in the canine model. In both cases, the probe was covered in a condom filled with degassed chilled water and then coupled to the gel or anterior wall of the rectum. During BH treatments, power was titrated up until a bubble was visible on ultrasound, and the power is then increased 5% further to ensure consistent treatment throughout the intended volume. Volumetric lesions were then produced, treating a grid with 1 millimeter spacing, treating 5 to 60 pulses per focus, and all tissue was then analyzed histologically after treatment. During ex vivo experiments, BH was effective in all cases, with a boiling threshold requiring a shock amplitude of 58 to 68 megapascals in both human and canine tissues. Treatment produced boiling bubbles at the focus, as seen on the beam mode ultrasound image there on the left, and this site correlated well on gross inspection of the tissue. Histologically, BH produced sharply demarcated fractionation in both canine and human tissue, though human tissue was more resistant, requiring more pulses for a similar effect, as seen on the right. Specifically, the human prostate with 15 pulses per focus demonstrated intermixed areas of homogenization and intact prostate stroma, whereas in the canine, ablation was nearly complete. And in the human, at least 60 pulses was required to achieve complete ablation of the entire volume, compared to only 30 pulses in the canine. Encouraged by these results, we then transitioned to our in vivo model, and similarly, BH was feasible in all canines with a boiling threshold of at least 88 megapascals in all dogs. Treatment produced nice hyperechoic bubbles during treatment, and over time this evolved to a hypoechoic cavity, which correlated well with gross tissue inspection and histology as seen on the upper right. Compared to ex vivo tissues, in vivo ablation had a similar appearance histologically, with a complete ablation seen centrally with as few as 5 pulses per focus. However, complete ablation throughout the entire intended volume required 30 pulses per focus, similar to ex vivo. And importantly, no collateral damage was appreciated either to the anterior rectal wall or periprostatic tissues. In summary, transrectal BH prostate ablation is feasible with a prototype preclinical transrectal device. Ex vivo and vivo prostate tissues appear to behave similarly, and in light of this, short-term survival studies are planned to further evaluate for complications, and in vivo oncologic studies are currently ongoing to establish the efficacy of BH transrectal prostate cancer ablation. And finally, human prostate is more resistant to BH than canine, and as a result, future studies will optimize pulse parameters to achieve complete ablation in the tougher human prostate. Thank you.